Good day, everyone. My name is Alfredo Baula Jr., and I will be presenting an orthopedic emergency case. That is why, with no further ado, let's proceed. To start with my presentation, let me first explain to all of you what are orthopedic emergency cases. Let's go. Orthopedic came from the Latin words orthos and pedia. Orthos meaning straight or correct, and pedia meaning rearing of children. Back then, orthopedics was used for children with skeletal deformities. But today, orthopedics is now referred to as a branch of medicine that deals with the care of skeletal system and the parts connecting it. In the next slide, I'll be presenting some examples of orthopedic or musculoskeletal emergency cases and what we need to understand about these cases. Most importantly, that these cases are major orthopedic emergency cases that are life-threatening in condition. As you can see in the picture, the man has multiple manifestations, including the most common of which is the open fracture and dislocation. Also, spinal injury and vascular injuries are notable. But today, what we're going to talk about is this. This is the compartment syndrome. Acute compartment syndrome, in a nutshell, is the increase in pressure in the compartments that cause a decrease in blood flow that further leads to complications just like ischemia, necrosis, and permanent disability. Today, I am going to share to you a case of acute compartment syndrome that happened in the US. Before I proceed with my case presentation today, I would like to give credits to Ms. Dorothy Christian, a nurse practitioner who is the owner of this case and who is the sole reference of my case analysis for today. Thank you, Ms. Dorothy Christian. As you can see in our case analysis for today, it is about a 43-year-old male who fell from the back of the truck at 6 feet high while unloading construction materials. The graphics here shows exactly that the man fell from the truck while he is working. So this is the primary case scenario of our analysis for today. Further information about the case: for social history and past medical history of our patient, the patient has a seizure disorder and on carbamazepine. The patient is married with 2 children and he works as a cement mason in a construction firm. The patient also smokes tobacco, approximately 3 sticks of cigarettes per day, and engages in marijuana occasionally. The following are the clinical manifestations of our patient. Number 1, the patient suffered severe pain, a score of 8 to 9 over 10. Next is that the patient's skin was intact, there was no laceration, therefore it is a closed fracture. The patient can still wiggle his toes upon assessment, and the pulses of the patient at dorsalis pedis and posterior tibial both have slightly diminished pulses at positive grade 2. Next is there is a significant early swelling upon assessment, and the capillary refill is at 2 seconds, which is brisk. Cut. Next is there was no decrease in level of consciousness because the patient is conscious with a perfect score of 15 in the GCS. And the vital signs of the patients are as follows: blood pressure of 158 over 90 mmHg, a pulse rate of 70, RR of 16, an O2 set of 95%, and a temperature of 38 degrees Celsius. Next is that the patient's actual appearance is in acute distress based on assessment, and upon assessment also, the patient cannot move his knees or cannot move within range because of the tenderness and the pain. Going to the laboratory test and diagnostic test of the patient, Based on the clinical manifestation and the history of the patient, the following laboratory tests are ordered and the imaging tests too. Since the patient is expected to have a fracture on the lower leg, X-ray was ordered. The X-ray I will further explain later on. Let's proceed first to the pre-operation laboratory tests. Given the patient's condition, he requires surgery, so pre-op tests are ordered. Number one is the CBC. The CBC is to check the blood components of the patient because there is unexpected bleeding inside. The next laboratory test is the basic metabolic panel or the BMP. This is a blood test that gives doctors the information about the body's fluid balance. This includes the electrolyte levels like sodium, potassium, and it generally tests how the kidney is working, like it includes the CREA and the BUN. Third would be the INR, or also known as the International Normalized Ratio, which check if you have a blood clotting problem because it tests the effect of blood thinning medications or anticoagulants for your patient. Fourth would be the seizure medical level. Since our patient has a seizure disorder, we need to check the carbamazepine levels of our patient. Next is a toxicological screen. A tox screen was also ordered because the patient had a history of marijuana use. And we need to know the levels of marijuana in the patient's blood system. Last would be EKG. It was ordered to monitor other heart condition since patient also has hypertension during assessment. This is also a requirement for cardio clearance for operations. Now, those laboratory tests are included, as well as the chest X-ray, because in coordination with an EKG, chest X-ray was ordered for the patient undergoing operation because chest X-ray is a need for pulmonary clearance. In the next slides, I will be presenting to you the X-ray of our patient in the right lower limb. As you can see in the picture, we can easily spot the fracture pointed by the arrow, and that is the plateau of the tibia, and then the tibial shaft itself. In this picture, the lateral view of the fracture, we can say that it is around 2 to 4 centimeters in the tibial shaft. Now that we know the basic knowledge of our patient, including the laboratory tests and diagnostic imaging tests, now let us know what is happening in this kind of emergency situation. This time, I am going to discuss the pathophysiology of acute compartment syndrome due to tibial fracture. Let's go. This time around, I am going to explain to you the pathophysiology of acute compartment syndrome. Starting from the top are the predisposing and precipitating factor on both ends of our diagram. The predisposing factor of compartment syndrome, in our case, of our patient, is the fracture of the tibia. When the tibia got fractured, there was a distraction to the internal bone and muscle and structure that also damaged the fascia or the covering of the structure. Meanwhile, the precipitating factor of our case is that the fracture of our patient is a closed fracture. When there is a closed fracture, we all know that the blood cannot exit, so the blood pools inside the cavity, increasing the cellular and extracellular volume, disrupting the homeostatic functions of our organs and parts inside. When we combine the damage to the musculoskeletal structure and the extracellular functioning, there is a disruption of the maintaining pressure for each organ or part to function accordingly. There is now an increase in the compartment pressure. At the center, you can see there before our circle, below the acute compartment syndrome, that is where the precipitating and the predisposing factors meet. As we all know in our anatomy and physiology class, the limb is divided into four compartments. And these compartments are now filled with blood and other chemical materials that was triggered by this condition. Now, what we need to understand in compartment syndrome is that this condition is a vicious cycle. The initial increase in the compartment pressure only implies more and more increase, which will further develop into the signs and symptoms that comprises this acute syndrome of compartment. I am going to refer to the first cycle above. When there is an increase in the compartment pressure, the pressure inside the lumen decreases. That is because the vascular structure are now compressed by the compartments of the limb. When the veins and arteries are compressed, there is now a decrease in the delivery of oxygen. The blood supply now becomes the problem. That blood supply problem will cause hypoxia, and that will activate anaerobic metabolism, which in return releases histamine and nitric oxide to help in the absence of oxygen. When this cycle continues, our first cycle above, the compression of the lumen will cause the arteries to collapse, referred to the right arrow, which cause pulselessness to the lower limb. That is because the decreased pressure in the lumen and the compression of the arteries and veins causes these blood vessels to collapse, causing them not to function. Also, on the left side of our diagram, we have the hypoxia to the tissue that will appear to have a pallor of the skin. Now also, the edema starts to present and the limb will become hard upon palpation. The further increase in the compartment pressure eventually leads to the formation of intracellular edema because, as I've said earlier, blood pools and blood cannot flow, which then causes hypoxia. Let us refer to the second cycle above. The further increase in the compartment pressure eventually leads to the formation of intracellular edema. Why? It is because blood cannot flow, which then causes hypoxia. The hypoxia prevents the mitochondria to produce ATP. Without ATP, in the intracellular level, the sodium-potassium pump cannot function, and sodium pulls inside the cells. When there is sodium, water follows. So the increased sodium levels inside the cell calls the water, and there will be swelling, which will eventually lead to lysis or the disruption of the cell, and then causes the protein inside the cell to leak, and then the cell will now die. Let us refer to the right arrow in the second cycle. When this pressure exceeds the vascular pressure, it damages also the sensory and motor nerves, which causes the feeling of pins and needle pains, which will cause paresthesia there, and then anesthesia, and later on paralysis. Referring to the left arrow, the increase in the compartment pressure further develops the sharp and deep stabbing feeling of pain that worsens when there is passive stretching in the limb. Also, the loss of the proper functioning of the structure inside. There is also the inability to regulate temperature to the limbs. So we'll now feel cold, or there is what we call as poikilothermic. Altogether, the signs and symptoms make the compartment syndrome. The further increase right here in the pressure and decreased blood supply will cause to necrosis of the tissue. In the end, will have loss of function. Then some cases, the development of contractures. Another is that there can be rhabdomyolysis to occur. The byproduct of rhabdomyolysis or breakdown of muscle is the creatine kinase and myoglobin. These two substances are toxic to the kidneys that will eventually cause acute renal failure. It is very important for us nurses to assess properly our patients so that we can prevent this kind of emergency situations. That is the pathophysiology of acute compartment syndrome. Let's proceed to the surgical and medical management of our patient. 1, 2, 3, action. As for the management of our case, first, the primary management is a decompression of acute compartment syndrome, and that is through fasciotomy. Next is the main yet secondary concern is the reconstruction of the fracture. And lastly is the prevention of any other complications. The primary concern of our case is that the compartment syndrome. The scenario of the case upon arrival to the hospital is that the tibial fractures presents with early swelling and there was worsening pain 6 hours after the admission. And the tissues were dense, so tense, so fasciotomy was immediately done. The plan of the management includes wound evacuation on fasciotomy incision, and then after that, there is a plan for return to the OR after 2 to 3 days to wash out the wounds and then to attempt to close the incision. There was also prevention of deep vein thrombosis, and there was an administration of enoxaparin via subcutaneous, and then the prevention of infection, thus the administration of antibiotics via IV until the fasciotomy incisions are closed. You can see here in our picture, this is the fasciotomy, the cut into the fascia to relieve the pressure inside the limb. And it is very important for us to routinely check the compartments of the limb due to tibial fracture with early swelling. So here, you can see that the lateral fasciotomy wound was done. That is in order for the perineal nerve center to be exposed and then the decompression to be started. Next here is the lateral fasciotomy after routine washout, and that is for the preparation of final wound closure. In this section right here is the unclosed incision when there is still wound vac remaining. And lastly, right here is the medial fasciotomy wound underwent delayed primary closure. That is the primary, because in our further management, we need to fix the fracture. First, address the compartment syndrome before we address the fracture. Action. After our fasciotomy, we're going to reconstruct the tibia. So the patient was discharged after the fasciotomy when the patient was stable, and then the patient was transitioned to oral medication, pain medication, antibiotics, and then the patient was taught how to take care of the pin site and the injection also of enoxaparin. When the patient was outpatient, the patient was asked to go back to the hospital after 1 to 2 weeks once the soft tissues recover. The patient was instructed to always remember to do non-weight bearing right lower extremities activities for 3 months after the final fixation. So in the next pictures that I will show you, it will be the X-ray of the final fixation or the ORIF of our patient. No, well, some bones can heal by wearing a cast. Others may require more invasive treatments, such as our patient, such bone of fracture repair. Bone fracture repair is a surgery to fix a broken bone using metal screws, pins, rods, or plates to hold the bones in place. It is also known, as I've mentioned, ORIF, or the open reduction and internal fixation surgery. So this is the picture of the X-ray of the patient after 34 days after. So this is the picture of our patient 34 days after injury, final fixation through ORIF of the tibial plateau and tibial shaft fracture and removal of the fixation. There, as you can see, that is as you can see in the picture, that the tibia was held by a rod and pins, and then plates so that it will be formed again. Now we've come to the most important part of our presentation, which was all about the nursing care plan. As nurses, we should bear familiarity to the nursing care plans of our patient. We have 3 nursing care plans for our patient. Number 1 would be acute pain related to injury to the right lower leg, secondary to fracture of the tibia. Second would be impaired physical mobility related to musculoskeletal impairment, secondary to tibial fracture. And last would be a risk for peripheral neurovascular dysfunction related to direct vascular and tissue trauma, secondary to acute compartment syndrome. Let's proceed to the first NCP. For our first NCP, we have acute pain related to injury to the right lower leg, secondary to fracture of the tibia. Now, what we need to remember is that our patient is suffering a lot of pain, and our patient is under pain medications. So what we need to do as nurses is first maintain immobilization of the affected parts by using bed rest, cast, splint, and traction so that we can maintain the position of the affected part of our patient. This immobilization relieves the pain and prevents further bone displacement and extension of the tissue injury. Next is that before we do any activities to the patient, we should medicate pain medications to our patient, no? So that the patient can have relaxation and enhances participation during the activities kasi the pain subsided. Third is that we should perform unsupervised active and passive range of motion exercises to our patient. Why is that? We need to do that. First is because we need to maintain the strength and mobility of the unaffected side, no? Because later on, the unaffected side will help the affected side to develop as well the range of motion. Second, it will also facilitate resolution of inflammation in injured tissue. That's what I'm talking about. It will help the unaffected side, will help the affected side to function later on in the recovery. Fourth would be provide alternative comfort measures by using massage, back rub, position changes. Now, because our patient has a limb fracture, basically he has difficulty in transferring, so we need to assist or provide alternative comfort measures to our patient. This improves general circulation and most importantly, this prevents the formation of pressure ulcers, reduces area of local pressure, and most especially muscle fatigue. Next would be our patient is in pain and we need to provide emotional support and we need to encourage our patient to have stress management techniques. There are a lot of stress management techniques now that includes progressive relaxation, deep breathing, exercises, visualization, and guided imagery or just like imagination. This refocusing of the attention promotes a sense of control, and this may enhance the coping abilities of our patient in managing the stress, the traumatic impact of the injury, and the pain as well. So that which likely to persist over an extended period of time. Lastly, this is a dependent nursing intervention, is we need to administer medication as indicated. Given to reduce pain or muscle spasms, analgesics around the clock for 3 to 5 days or depending on the doctor's order. There is a study that I have read that ketorolac or toradol have proven effective in alleviating bone pain with longer action and fewer side effects than narcotic agents. So yun. That is for our first NCP. Let's proceed to our second NCP. For our second NCP, we have impaired physical mobility related to musculoskeletal impairment secondary to tibial fracture. Now, in connection to the pain and to the fracture, we should understand that the patient cannot move properly because there is a problem in the limbs. And the limbs And the right lower limb of the patient primarily supports the patient to stand and to do activities. So first is we need to teach the patient or assist with active and passive range of motion exercises of affected and unaffected extremities. This this intervention increases blood flow to the muscles and bone, and that improves the muscle tone and preserves joint mobility. Now, we should be preventing contractures or atrophy and calcium resorption from disuse of unaffected extremities. So, this intervention primarily prevents any other complication to occur. Next is because of some reasons, no, there is a decrease in parang there is a decrease in the activities of our patient. There is a decrease in the activity of our patient because of these impaired physical mobility. So, second intervention is we need to encourage participation, diversional or recreation activities, and maintain a stimulating environment, no, because the patient is not contraindicated for like entertainment activities such as radio, TV, newspaper, personal possessions like look at pictures, having calendar, and having family visits and with friends. This provides an opportunity for our patient to release energy to refocus the attention, and that the problem in impaired physical mobility will not cause further psychological or like impact to the self-confidence of our patient. No. It enhances patient's sense of self-control and self-worth and aids in reducing social isolation. Third is that the most Third is that we need to prevent foot drop, no? We need to provide footboard to our patient by also wrist splints, trochanter, and or hand rolls as appropriate because the functional position of extremities, hands and feet, and because that is very important to prevent complications, as I've said, foot drop, contractures, and that is very difficult when that happens. Next is that since the patient cannot move properly, we should assist the patient with self-care activities like bathing, shaving, toileting, and others. This improves muscle strength and circulation, which will enhance the patient's control in situation and promote self-directed wellness. Next would be we need to reposition the patient periodically and encourage the coughing and deep breathing exercises. Why we need to do this is that we need to prevent or reduce the incidence of skin and respiratory complications. No? Number one problem for impaired physical mobility is the formation of decubitus ulcers and atelectasis and pneumonia because the lungs cannot exercise properly because the patient is just lying down. Next would be instruct the patient to and encourage the patient to use a trapeze and post position for lower limb fracture. No? Why is that we need to do this? To do this is that because we need to facilitate movement during hygiene or skincare and linen changes. Now that will reduce the discomfort of the remaining fat in bed. Post position refers to involving the placing of the uninjured foot flat on bed with the knee bent while grasping the trapeze and lifting the body off the bed. So it's like helping the body to move. Now, the trapeze will help the patient move his or her body if he cannot, and that will primarily help in self-control and self-worth that the patient will think, oh, I can still do this, I can still move my body with the help of this equipment, and that will eventually develop good feelings of the patient. NCP, the third NCP would be risk for peripheral neurovascular dysfunction related to direct vascular and tissue trauma secondary to acute compartment syndrome. No? Peripheral neurovascular dysfunction is somehow expected to patients with fracture because the direct vascular and tissue trauma involves the motor and sensory nerves or neurons because of that compartment syndrome. That is why we need to assess first the capillary return, skin color, and warmth and distal to the fracture. The return of color or the capillary test would be 3 to 5 seconds. That is not allowed. It should be rapid. It should be rapid. White cool skin indicates arterial impalement, while cyanosis suggests the venous impairment. We should take note about the peripheral pulses, just like our patient. the capillary refill, the skin color, and most importantly, the sensation. It should be normal. The patient should feel the prick with the pin and the slide of the cotton. That is a sensory test we need to do, and that we need to evaluate that the circulation is not compromised. Next is we need to evaluate the presence and quality of peripheral pulses distal to the injury via palpation or Doppler. And we need to compare this to the uninjured limb if possible. No, like for example, earlier, in our case, it is stated that the patient has a slightly diminished pulse, no, grade 2, and that we need to check always the pulses of our patient distal to the injury. Now, what happens pala when there is a slightly decrease in pulses, no? A decrease or absent pulse may reflect vascular injury and necessitates an immediate medical evaluation of circulatory status. Be aware that itong ating mga pulses, our pulses may occasionally be palpated even though circulation is blocked by a soft clot through which the collapse happen, no? It may be felt. In addition, also, the perfusion through larger arteries can continue to increase the compartment pressure after the arterial or the venous circulation collapse in the muscle. So, kailangan natin yan i-assess. Next is we need to assess also the tissue around cast edges for rough places and pressure points. No, we need to know if there's a burning sensation under the cast. No, like because we need to monitor for ischemia and that the burning sensation indicates a tissue pressure and that will lead to breakdown and necrosis. That would be factors of our ischemia. Next, we need to monitor lab tests just like hemoglobin, hematocrit, and the prothrombin time levels of our patient so that the blood loss and the effective replacement therapy can be done. And then we need to also to know the coagulation deficits of our patient that may cause secondary complications, just like trauma, or if there is a presence of fat emboli, we need to understand also the anticoagulant therapy of our patient. Lastly, we need to avoid elevation and application of ice when the acute compartment syndrome is suspected. Why is that? No, because elevation and ice application aggravates the impaired vascular supply in an extremity that already experiencing ischemia due to developing compartment syndrome. No, because when we raise the foot pa, the gravity, the blood supply of the feet will go to the central system pa, central circulatory system, and that there will be no remaining circulation to the lower limb. And also, what is the function of eyes? No, it the function of eyes is that it is a it constrict blood vessels. It constrict blood vessels, and it will help in the compression of the blood vessels more. So it is a no-no in compartment syndrome. So those were very important topics for our NCP. I hope that you remember all of those. So here are the list of my references for my case presentation. That would be all. Thank you very much and goodbye.